Hello, everybody, and welcome to March's edition of St. John's Cancer Institute's Be Inspired Speakers Series. Today, we're going to hear about colorectal cancer, prevention, screening, and the rise of colorectal cancer in young adults. My name is Jean Goldsmith, and I'm a Director of Development at St. John's Health Center Foundation. St. John's Cancer Institute, our name as of January 2021, probably sounds new to many of you, as you've known us as the John Wayne Cancer Institute for many years. At the end of 2020, the licensing agreement between Providence, St. John's, and allowing us to use the name and likeness of John Wayne on the Institute expired. Going forward, the Institute will now be known as St. John's Cancer Institute. The change is in name only. It will not impact how the Institute works in any way or its operations, and the fellowship program will now carry the name of the physician who founded the Institute and be called the Donald L. Morton, MD, Complex General Surgical Oncology Fellowship Program. St. John's Cancer Institute will continue to provide excellence in research, education, and cancer care through innovative clinical trials and laboratory research, the education of the next generation of surgical oncologists and scientists, and of course, state-of-the-art treatment for our patients. Going forward, we will expand and deepen the focus of our main pillars of cancer research: immunotherapy, genomics, and precision medicine. Before we get started today, I want to give you information that will help you ask questions of our speakers. As you will notice, everybody but the presenters are muted so that you will all be able to hear them well. In order to ask questions, which we hope that you will do, you will need to use the chat function on your screen. The chat function looks like a thought bubble, and it's found at the bottom of your screen. We will see your question and ask the physician. If I do not get to your question, or Dr. Martin doesn't get to your question by the end of the webinar, I will follow up in an email to you with an answer. If you have a question after the webinar, please email us and we will get the answer to you. You can find our email address by replying to the emails that we have sent to you. We have a very interesting hour in front of us as we will learn about our work in cancer treatment and research. We will briefly hear how the Cancer Institute pivoted to support research and treatment during the COVID crisis, and that work is still ongoing. And we will discuss prevention, screening, and the rise of colorectal cancer in young adults. You have received information on our speakers, so I'll let you read their full bio. I'm very honored to introduce the panel, who are physicians focusing on genetics, gastroenterology, and surgical oncology. I also wanted to let you know that Dr. Anton Bilczek, who was originally going to be a panelist on this call today, will be unable to be here. But we are very fortunate to have Dr. Trevan Fischer here with us, and we'll look forward to hearing from him. One of our panelists today is Dr. Rudolph Bedford. He is a gastroenterologist at Southern California Gastroenterology Group and the Director of Gastroenterology at Providence St. John's Health Center. He is a clinical associate professor of medicine at the David Geffen School of Medicine at UCLA. He also is the past president of the Southern California Gastroenterology Society. Dr. Bedford is the endoscopic guru in Los Angeles and is highly regarded for his expertise in pancreatic biliary disease. Our second panelist is Dr. Ora Gordon. She is a nationally recognized expert in hereditary cancer and is the medical director of the Regional Center for Clinical Genetics and Genomics for Providence, Southern California. She is the clinical director of the recently established Providence St. Joseph's Health Population Genomics Program and the principal investigator for the system-wide Geno4ME study. Dr. Gordon is board certified in internal medicine and medical genetics. Her primary research interests include identification of hereditary cancer in the general population and individualizing risk for common disease. Passionate about the holistic approach to medicine, she also completed a fellowship in integrative medicine to expand options for primary prevention and nutritional research for high-risk patients. Dr. Gordon has also co-authored an award-winning book for women facing genetic risk for breast and ovarian disease called Positive Results: Making the Best Decisions When at High Risk for Breast and Ovarian Cancer. And our third panelist today, Dr. Trevan Fischer, is an assistant professor of surgical oncology at John Wayne Cancer Institute and the assistant program director of the Donald L. Morton, MD, Complex General Surgical Oncology Fellowship Program. Dr. Fischer is very interested in minimally invasive and innovative surgical techniques and teaches this to the surgical oncology fellows in our program. While he does not have much spare time, what he has, he spends chasing his darling 2-year-old daughter. And moderating today is Dr. Neil Martin, the Interim Executive Director of the St. John's Cancer Institute. Dr. Martin is a neurosurgeon and is also the Regional Medical Director of Neuroscience for Providence, Southern California, overseeing neurosciences for Providence hospitals and clinics across all of Southern California. Dr. Martin?
Good afternoon. It's a pleasure to be with you as we talk about colon cancer. And it's something that you hear about almost invariably at some point during your life. And we hear a lot about screening. We hear some things about colonoscopy. We hear about surgical techniques. And most people have a lot of questions about colon cancer. So I'm going to start with Dr. Gordon, if I could. Dr. Gordon, what are the risk factors that indicate that you might be at higher risk for having colon cancer?
So this is such an important question. And, historically, we had very strict guidelines about family history. Somebody had to be very young, under the age of 50, had to have multiple family members with colon cancer or potentially related other kinds of cancers, gynecologic cancers being very strongly associated with hereditary risk. But what we've learned in the last few years is that those models of very strong family histories don't capture enough of patients at risk. And so we have started to shift away from this very strict, you have to have this incredible family history of cancer, to start to look at, much broader populations. So unquestionably, early age of onset is an indication for genetic testing, hereditary cancer testing for colon cancer. But beyond that, we start to really look now at people who have early onset polyps, people who, if you have a polyp at the age of 40 or around there, might be an indication that you are at risk. And even beyond that, we're now, as was mentioned in the introduction, really looking at populations, because the hereditary cancer syndrome that is the most common associated with colon cancer is something that is named after a professor who described it. It's called Lynch syndrome. And this family of genes that 1 in 300 people in the general population, and as many as 1 in 20 or 25 people who have had a history of colon cancer, regardless of how old they are, have a hereditary susceptibility. So it's just an incredibly evolving space in terms of recognizing who may be at risk.
Yeah, that's very helpful. What just to take a slight step backwards, how many people during their lifetime develop colon cancer? Where does it rank amongst cancers in its frequency and incidence?
You want me to answer that? Dr. Bedford, you want to?
Dr. Bedford, you want to take
I'm happy to. So about 5% lifetime risk of colon cancer, approximately 140,000 people or so every year in the United States are diagnosed with colon cancer. So it ranks at least number 3 of all cancer deaths in the United States.
Okay. All right. It's, we're hearing that colorectal cancer is on the rise among young adults. What's the story behind that?
Well, I'll take on that one. It's quite frankly very puzzling to us. Over the last 30 years, the incidence of colorectal cancer has increased by upwards of 51% in people who are the ages of 18 to less than 50, surprisingly, while at the same time, the incidence for older age onset has decreased by at least 20%. with the onset of colonoscopies and the decreasing smoking. So, it's quite frankly projected that by 2030, about 10% of all colon cancers will arise in people less than the age of 50. And about 22% of all rectal cancers are projected to arise in people under the age of 50. There are many aspects to why we're seeing a higher rate of colon cancer in younger individuals. People propose diet, sedentary lifestyles, maybe even the biome of your colon and small bowel. But quite frankly, we don't completely understand it yet.
Dr. Gordon, how should you discuss your family history when you're being evaluated by a general practitioner so you can include the relevant things that might relate to cancer?
The first thing, to follow up on Dr. Bedford's comment, so absolutely, we're seeing an increase in the, colon cancer in a younger population, and it is not because there are more genetic mutations. So I just want to clarify that that's not what's driving it. We recognize that there is a more substantial component of hereditary cancer than was ever understood before, but that doesn't fully explain what this huge uptick is. And there has been a lot of work looking at things that we call epigenetic modification. So what is happening to, the DNA that are the cells that program everything in your body, as well as the on the local level of in your gut, and are they being altered and modified based on our environmental stressors? So that there's a lot of work going into looking at that. When you are, approaching with your primary care physician or whomever your care provider is, every patient should be their own best advocate. Yes, we have great tools to help people create their family history trees. There are a lot of things online to help those resources. Primary care physicians are super busy and very heavily committed to a lot of things that they're trying to get through. So you as the patient need to be the one bringing that forward. What are the kinds of things, these patterns that we see? What I tell everybody is really, when you get together at Thanksgiving or your holiday, in addition to, passing the mashed potatoes, is get that family history. Try to clarify those things in family members. There's a great deal often of this unclarity related. Oh, grandpa, he had abdomen cancer. So to try to get that clarity and try to understand what that is, to be able to be empowered to take that forward. So you really want to know it's the three generations of your parents, your children, your siblings, and your grandparents for the most part, aunts and uncles. That's the component that will have the most influence on you, both on the paternal and the maternal side. So you can have your dad's family have tons of breast and ovarian cancer, and it is still relevant, even though it's coming from your father's side. Colon cancer, GI cancers are gender agnostic, but the kinds of things that go together with some of these syndromes may seem like they're not at all connected. So people think about everything in the GI tract as being connected, but if you have colon cancer and uterine cancer, ovarian cancer, pancreatic cancer, those are all tied together. Breast cancer and colon cancer. So really, it's not for you to sort out whether or not, this is an important family history. It's really to just bring that forward. And that's also why we're pushing so hard to really start to look at population level risk, because some people just don't know their family history. People are adopted, estranged, all kinds of things. And so we're really trying to push out the requirement of having some stringent family history.
So Dr. Bedford just indicated that 5% of people will have colon cancer during their lifetime. How much higher is that if you have one parent with a history of colon cancer? Dr. Gordon?
So,
excuse that one.
Yeah, so we have a lot of empiric information that's very helpful, and we've changed our guidelines of when we should start colonoscopy screening on the basis of family history. So if you have a first degree relative, which is a sibling, a parent, or a child who has had colon cancer, then you should begin your colon cancer screening earlier. And it is based on how early that cancer, potentially how early the cancer was in the family. And then the frequency should be more frequent. And that's just what we call empirically. That's just on the basis of the family history. Because we have now a dozen genes that increase the risk for colon cancer from very high risk to pretty modest, there is a lot of nuance in terms of how frequent somebody should be having a colonoscopy, or should they be having other interventions in between that. But really the kind of benchmark is to think about 5 to 10 years earlier than the earliest cancer within the family.
Okay. And if you had to say how much it increased, does it double your risk from that 5%?
I'm sorry, yeah, that was your question. Yeah, so about a doubling of risk if you have a first degree relative that certainly under the age of
10% is a pretty significant risk.
right. And if you have a hereditary susceptibility, that risk can go up to about 70% lifetime risk.
Wow. So the family history is critical, no question about it. So we hear a lot about screening, Dr. Bedford. There are a lot of techniques available now, non-invasive techniques, endoscopic techniques, radiographic techniques. How does someone think about the sequence of screening testing that they should be doing?
Well, you are speaking to a gastroenterologist, so from where I stand, colonoscopies are the gold standard. Without a doubt. Now, there are other testing methods. I'm in the business of preventing colon cancer, not discovering it. So for those techniques where colon cancers are discovered, we do have genetic DNA testing of stool, so-called Cologuard study. We can detect blood, and we do have immunohistochemical staining from stool, again, all used to detect colon cancer. There are radiographic techniques that are not used much these days, but they consist of barium enema studies. And of course, there is a CT scan colonography, which can detect polyps. But unfortunately, the preparation is the same as you'd go through with a colonoscopy. So as a gastroenterologist, certainly we would encourage those people who can undergo one would be a colonoscopy, typically starting at the age of 45 now is the new recommendation.
Okay. So you're hearing more and more about Cologuard. In fact, you're seeing ads on TV about it. But does that only pick up cancer and not pick up polyps?
No, certainly it does pick up adenomatous polyps at a lesser rate of sensitivity and specificity as opposed to cancer. But and as a matter of fact, most of our positive Cologuard studies are in fact polyps that may be predisposed to becoming cancers as time goes on.
And are there symptoms that people should be looking for that may trigger urgent colonoscopy or a real high risk of colon cancer?
Well, certainly anybody that has blood in the stool, we're always concerned. And these days, even those people who are less than 45 years of age, unexplained anemia, abdominal pain, weight loss, change in stool caliber, and even just persistent abdominal discomfort and pain. And sometimes we will mistake this for a syndrome such as irritable bowel-like symptoms. May very well be somebody who you want to have a high index of suspicion.
Mm-hmm. Okay, very good. Dr. Gordon, what, for someone who is who's younger and healthy, what can they do to reduce their risk of getting colon cancer?
So one thing I want to talk about is a new program that we have at St. John's that, talking about the family history and trying to identify risk and how do we figure out who's at risk. We're launching a number of initiatives, the first of which is going to be through our mammography, actually, screening with a chatbot. So using AI, having people fill out a personal and family history, very brief interactive survey to determine whether or not they meet what are the current national guidelines for hereditary cancer risk assessment. So in this way, we're really trying to broaden out and reach people who may not even realize that they might be at elevated risk, that they had a family member or their remote history from a long time ago and just hasn't been addressed. So that's one thing that we're trying to really do to capture and individualize care for all of our patients at St. John's. And very excited about that. One of the key risk factors in there is for hereditary colon cancer and hereditary GI cancers. So for the younger individual, the low bar is to avoid the category 1 carcinogens. So in your diet, everything that you get in an Italian deli, basically, that's delicious, is what you should not be eating on a regular basis. So foods that are highly processed, nitrate containing, have been cured, are all by the International IR Consortium considered a carcinogen. So that's an easy thing to avoid. When we see, when I see patients who are at elevated risk, either on the basis of finding one of these moderate, pretty common moderate risk genes for colon cancer, I put them on low dose aspirin if they otherwise aren't contraindicated. Aspirin has great data in terms of prevention for the formation of these predisposing adenomas, as well as for colon cancer. Patients who are at high risk and are identified as having hereditary cancer, we put them on high dose aspirin if they can tolerate it. And certainly younger people are much more likely to tolerate it. Always have them get their colonoscopy and upper endoscopy, make sure that they're not at any bleeding risk beforehand. There is some early data, and I want to open the floor to anybody else in terms of wanting to discuss this. You know, the issues related to obesity and sedentary lifestyle, and really trying to figure out what are we doing in terms of our first world living that is really increasing our rates of colon cancer. This is, again, kind of the opportunity to, how do we teach our children? How do we model behavior and dietary consumption? The decrease in smoking has been a great advantage in our older population, as has adherence to surveillance and being able to take out a polyp. If you take out an adenoma, that adenoma cannot turn into cancer. So I want to turn the floor over to Dr. Fischer and Dr. Bedford. I want to add them something there.
Great. Dr. Fischer, we mentioned the higher, the more recent higher incidence of colon cancer in younger patients. Do they present, do they appear to consult with a physician with any specific unique type of symptoms?
Yeah, so I mean, there's a spectrum of presentation. I think the younger population, the under 45, it's been sort of ingrained in our heads forever that not start thinking about colon cancer until you're 50. And I think because of that, I think we do see some patients who have, they have some blood in their stool and they think, oh, I've just got hemorrhoids. It's pretty common, not to worry about, and they probably are in that 10 feet tall and bulletproof stage still, where they think nothing's like this is going to affect them. So we definitely see across the board, we see all presentations where patients present with a more advanced disease because they sort of not necessarily neglected, but they've ignored some of the symptoms that we would probably pick up on earlier. I think the older population sees their physicians more often and they're asked these questions, and so there's a little bit more input from the medical community when you're seeing a doctor regularly. And I'll be honest, not a lot of 35-year-olds go to a primary care on a routine basis. And so I think because of that, we do see some later presentations. So,
Dr. Bedford, you hear about colonoscopy, but there's also sigmoidoscopy. What's the difference, and what's the general recommendation?
So the sigmoidoscopies, at least 15 to 20 years ago, used to be part of our screening regimen for colon cancers, but we have found that a large percentage of colon cancers and polyps actually present in the right side of the colon. The sigmoidoscopy may be inserted into the colon, but we'll see potentially the first third of the colon or the left side of the colon where there may be a number of polyps that can be found. But again, we have found over time, and I'll give you a precise number, over 40% of polyps are actually found on the right side. So the sigmoidoscopies are typically left to people who are having bright red blood rectum, and we're looking for something in the lower end of the colon, whether it's a polyp or hemorrhoids or something else that might be bleeding. But for the most part, if you're over the age of 40 and you're having bloody stools, you are going to receive a colonoscopy because, again, as I said, many of these lesions are found on the right side of the colon.
This Lynch syndrome hereditary colon cancer also has a predominance of being right-sided. So importantly for screening, the same reason why that those individuals who are at higher risk get a colonoscopy and not a sigmoidoscopy. One of the other things that we're doing at St. John's, which a program that got started when I came over about 5 years ago, is universal assessment of all our colon cancers. So we've talked a little bit about these, early age of onset and the two things that are happening. One is that we recognize that the earlier age of onset is associated with a hereditary susceptibility, but we're also just seeing younger folks getting colon cancer. Pair that with that about half of people who have a hereditary cancer susceptibility don't meet the current guidelines for hereditary cancer risk assessment. So we started a universal screening in the pathology. There doesn't need to be any order. There doesn't need to be any, indication based on family history for all colon cancers and actually all uterine or endometrial cancers to be screened through a laboratory test called immunohistochemistry or IHC screening to look to see are the proteins present that are associated with this Lynch syndrome. And in that way, we have a full loop. If that is absent, indicating it may be Lynch syndrome, doesn't matter how old the patient is, doesn't matter if they have a family history, if they've had other cancers, that becomes an automatic referral that the genetics department then communicates to both the patient and the physician of record that this individual may be at high risk. And then that way we have been able to capture and test our patients as point of care as they're making all of their decision making related to what kind of surgery do they need, adjuvant or chemotherapy, and kind of managing their future risk. So this has really been an important transformation because we were missing a whole bunch of folks who actually had hereditary susceptibility. That said, that the testing that we're doing in pathology is specific for this Lynch syndrome. And there are many other genes that can predispose to colon cancer susceptibility. So that's where, the providers of patients have to lean in and say, okay, well, my screening test, my IHC was normal, but I'm 42 with colon cancer. Do I need genetic testing? Absolutely. We have to be able to sort that out. And then when we find nothing, then that person is managed in a way that's just related to their colon cancer. And if we find a genetic susceptibility, that may really change the frequency that they are getting screening. That may change what other extra outside the colon conditions that we're looking at, and then very relevant for their family.
Thank you. So Dr. Bedford, if you during a colonoscopy, if you identify cancer, can it be cured endoscopically through colonoscopy?
So very rarely we may find what we used to call a cancer in situ in a large polyp, and we may be able to remove it endoscopically where the margins of the area are negative for cancer. But again, this is a very rare circumstance. For the most part, most of these patients are referred on to our surgical colleagues, such as Dr. Fischer, for resection of that cancer, because at the time of resection, they can also strip the lymph nodes in the vicinity to make sure that there is no disease that has potentially spread throughout.
I see. Thanks. So Dr. Fischer, tell us about the surgical options when colon cancer is described, is defined, is identified.
Yeah, so sort of two main things I think of when I get a new diagnosis of a colon cancer. First off is where is it sort of within the colon? As we all know, the colon's many feet long, and sort of where it is, either proximal colon or distal colon or somewhere in between, helps mold the operation. I think Dr. Gordon's point about knowing that genetic susceptibility is important to know early on as well, because that may influence the surgical technique we do as well. Some of those patients, we sort of take care of their cancer and also decrease the risk of other cancers forming by taking out a majority, if not all of their colon, at one operation. And so having that information up front is important to have. From a technical standpoint, traditional colon surgery has been done through an open technique, which is the sort of a midline incision. We're able to mobilize the colon and in the majority of cases able to do an anastomosis or a connection to be able to put the patient back into continuity. Now we, with advances in minimally invasive surgery, starting with laparoscopy, which is using small incisions to do the surgery that we would normally do as an open technique, and to now even doing it robotically, where we're able to have more of a three-dimensional view of the inside of patient's abdomen. We prefer that approach because, one, we can minimize the length of the incision in the majority of the patients, minimizing pain medication that's used, decreasing the stay in the hospital. There's a whole host of reasons, and lots of studies have shown that the cancer outcome, so we're not sacrificing we're not risking getting enough lymph nodes, as Dr. Bedford mentioned, which is a very key component of surgery. By doing it in a minimally invasive way, those are comparable. And a lot of patients prefer that approach to get out of the hospital faster, have less pain, less hernia risk. And there are times, to be honest, mostly deep down in the pelvis, where actually, because of the visualization that's aided by the robot, we can see better. And I think the surgery is technically easier to do using those techniques. And so it's a lot of things going into those accounts. Patients who've had a lot of previous abdominal surgery may have a lot of scar tissue, making it hard to do it with the minimally invasive approach. And so we sort of consult most patients that will start in those ways. And then if we need to, we'll complete the surgery in the most safest and effective way.
What percent of patients really need an open operation?
That's, probably, there are about 15% that are converted. So the starting off laparoscopically and for whatever reason needs to be converted, whether that's early or later in the course. Starting off laparoscopically, sometimes I would say probably about 10 or 15% as well. If the patient has an obstructing lesion and the colon is really dilated and we just don't have enough space to work in a minimally invasive way, it's better off to do that procedure starting off as an open procedure to be able to do it safely. And so doing things obviously safely and doing the right cancer operation sort of are number one and number two. And then sort of the other side, the positive things that come with minimally invasive approaches are down the line.
So people are worried about having colostomy. How often does that happen? How often is that necessary? What are the circumstances in which that's necessary?
Yeah, so we try to avoid a colostomy at all costs. It's although we made a lot of advances in how we manage patients with a colostomy, whether that's improvements in the actual appliances that patients use, and so we've gotten a lot better at that. It mostly depends on exactly where the cancer is. If it's a cancer is very, very low in the rectum, and we don't feel that we can safely make a connection while providing, function and continence and stool continence, there are times where we feel that the better outcome would be a colostomy. There are some, very, very distal cancers that the surgery is to remove the lower rectum and part of the anus. And in those situations, you really can't avoid giving someone an ostomy. In the majority of times, if we need to do an ostomy, we're able to, we would call it a temporary diversion or temporary ostomy, and we're able to go back in 6 to 8 weeks later, and that sort of allows for healing. It sort of protects the connection, the anastomosis, so we can go back later once we've confirmed, whether it's through imaging or through a scope, that the connection is well healed. And so, we try to avoid them if we can, but in some certain cases we just can't.
Is there, is it true that the vast majority of colon cancer operations can be done without an ostomy?
Yeah, for certain. Yeah, I would say overwhelming colon cancer. We separate colon and rectum. The vast majority of the colon, the more proximal lesions, it's very, very rare to have to do even a temporary ostomy. The lower you get in the rectal cancers, especially if they've had some treatment with radiation, chemotherapy up front, we sometimes protect those. And so it's still the majority of the time, I think probably in the time that I've been in my training and in my, in my career, we've gotten more aggressive at not doing ostomies and sort of following these patients and very closely. One of the other things that we can do now, I think helps the risk of having those connections be tight and sealed, is actually doing the anastomosis or the connection inside the abdomen. And so less stretch. In the traditional way, we would sort of pull up the bowel into the out a small incision, and that puts a lot of stress on the incision. And now we're actually doing these connections sort of where the bowel are supposed to be laying. I think that what we'll find over time is that's a better technique to be able to avoid having complications from those connections.
Yeah, Dr. Gordon, I wanted to go back to one thing you said. You mentioned aspirin as a preventive strategy. Should all of us be taking aspirin to prevent colon cancer?
So, there were some very large clinical trials looking at aspirin as primary prevention for all comers. And originally that was considered a negative trial, that there was not enough benefit seen against a risk for bleeding in the all comers. When they did a subset, kind of looked at a little more closely, anybody who was at an elevated risk for colon cancer, so that could be because of the family history, because of a prior history from having polyps, because they had been identified as having hereditary susceptibility. Now, there does seem to be the benefit exceeds it. The duration, aspirin and the whole pathway of the anti-inflammatory medications is pretty profound, and we have studied it in the hereditary causes of polyposis syndromes. So for people who make tons of polyps, as well as in the Lynch syndrome for people who don't make a ton of polyps but have very high risk for colon cancer. So the short answer is that don't uniformly recommend it to everyone, but is certainly a good thing to discuss in terms of risk and benefits, and really be part of a shared decision making. And Dr. Bedford and Dr. Fischer, I don't know if you want to add anything further than that, but the high dose aspirin studies are 2 full strength aspirins. That study was done in Lynch syndrome patients. They gave 2 full strength aspirins for 2 years, and there was over a 40% reduction in all cause cancers, not just colon, but every cancer associated with Lynch syndrome. So a profound benefit. Wow. And ongoing studies now are, what's the lowest dose that's effective to balance the bleeding and then what's the duration? Do we put people on it for a couple of years and then stop for a couple of years? When's the optimum time to start? Those we don't have an answer to, and those are ongoing studies.
Huh. So everybody with Lynch syndrome is getting aspirin pretty much, unless there's a contraindication.
Right.
Yeah. So Dr. Bedford, after somebody has surgery like Dr. Fischer just described for colon cancer, what's the need for additional therapy, radiation therapy, chemotherapy, immunotherapy, follow-up? What comes after?
Well, much of this is determined by the patient's oncologist, but typically depends upon whether or not there is any lymph node involvement or spread outside of the wall of the colon that will determine whether or not chemotherapy or radiation would be preferential. And again, these decisions are typically made by the oncologist. Where I come in is certainly with future screening. Typically, once a patient has been diagnosed with colon cancer, depending upon its location, once it's removed, they do require a colonoscopy within a year of that operation, and then at a minimum every 5 years moving forward.
Oh, that's good. That's good. I was going to ask that. Terrific. Well, we got a couple questions coming in. Just before I get to those, one more, Dr. Fischer. How many patients who have surgery, what percentage of patients have surgery need no other additional treatment, are cured by the surgery alone?
Yeah, so it all depends on presentation. And as Dr. Bedford mentioned, really lymph node involvement is sort of the number one thing you look at in your specimen, in your pathology report. If the lymph nodes are involved, then we know there's a benefit to getting what we call adjuvant chemotherapy, and that's sort of treating in the absence of no distant disease, so nothing in the liver, nothing in the lungs, or outside of sort of that area that we can resect. Getting a course of chemotherapy is needed. I would probably be guessing a number if I gave you one, but a lot of cancers, early stage negative lymph nodes, they just need screening. And we do screening exams, we check CEAs, which is a lab test that sometimes can be elevated in colon cancer and can detect recurrences. But I sort of would be, I think I'd be guessing a little bit at exactly the overall number of all comers who need that. Okay. But I think the other point, real quick, I wanted to touch on that Dr. Gordon mentioned, sidedness matters in colon cancer now. And so before we sort of just thought of colon cancer as one, organ and one organ cancer. And now we know there are differences in presentation of the right versus the left side. We use for therapy, some of the immune therapy drugs work better in cancers who have, high mutational burdens, and those are found on one side versus the other. And so it's not just a colon cancer. There's more factors that go into, where exactly the colon cancer is within the length of the colon too.
Okay. All right. We have a couple of questions that have come in. First one from Pam. If my mother got colon cancer at 79 years old, would that change the frequency that I need colonoscopy? And do my other adult children need to be screened, Dr. Gordon? So mother had colon cancer at 79 years old. Does that change the frequency of colonoscopy, and how about screening adult children?
So the current guidelines based on the NCCN or our national guidelines for somebody who has a first-degree relative with colon cancer is to begin at age 40 and then every 5 years. And Dr. Bedford certainly can comment on unless there's some findings, in which case then it's tempered by whether there are polyps found, adenomas, and otherwise. And in the case of this individual, I don't know how old she is, but so if she has, presumably if she has adult children, that she's already into the age of colonoscopy screening. The fall away, so once you get away from, the longer the in-between relative goes with nothing, the less impact it has for the next generation. But I wanted to take a moment to say that even in people who don't have a known hereditary susceptibility, so in this family, so one colon cancer at age 79 meets no standards whatsoever to do hereditary risk assessment. But because of the accessibility of genetic testing now, one could screen. And because there are these low, what we call low penetrant or low risk, but very high frequent genetic changes, that could also help inform how often to do colonoscopy. That genetic testing now, because of technology and cost and competitiveness, can be as low as $250 cash for those who don't meet clinical criteria. So it's really broadly accessible. there's another whole other mechanism to look to see if somebody is at higher risk for colon cancer. It's too much to sort of describe now, but it's something called polygenic risk. And that's looking at tiny variations in our DNA to say, are you a little bit higher risk or not? And we're looking at this in all common diseases: colon, breast cancer, prostate cancer, coronary artery disease. So that's all about kind of moving towards this precision medicine approach to say, you as an individual, how often and how frequently do you need any kind of surveillance? Dr. Bedford, any additional comments you'd want to put on there?
Well, our guidelines, somebody who's 79 years old with colon cancer, typically you would start doing colonoscopies at a minimum 10 years to that incident cancer. So we would still, I would agree with you that this person with adult children, likely at the age of colonoscopy, is beginning at 45 and 50 anyway. And in terms of surveillance moving forward, there might be some debate as to whether or not you would be screened every 5 years versus every 10 years. And much of that may very well depend upon whether a polyp is found in your colon to begin with, and if it is an adenomatous polyp.
Yeah, so another related question came in from Mary. Do you advise in-home cancer screening tests if you've been told you don't need another colonoscopy for 10 years?
Well, I'm assuming that that question is geared towards me, and certainly with the advent of Cologuard, we are certainly seeing quite a few patients who are getting tested. But when we talk about testing over the ensuing years before your next colonoscopy, we're really talking about your primary care physician just performing stool guaiac cards or FIT testing. But to go as far as doing things such as Cologuard, I'm not sure that there is really any data to support it one way or the other. Although only because with the Cologuard tests, there is a reasonable incidence of false positive test. And so we're doing, our burden of colonoscopies have truly gone up with this test. And I can tell you as an endoscopist, it is quite frustrating looking at a normal colon with a positive Cologuard, because you're always concerned that you might be missing something.
Yeah, I can imagine.
Yeah.
Here's another question about family history from Placilda. My husband was diagnosed with colon cancer at age 31. He was seen back in the early 90s. He had genetic testing and mutated cells were found. We have 4 children. All of them had colonoscopy starting at age 20. So far, none have been diagnosed with colon cancer, but 2 of them had polypectomies. So the question is, should the children get genetic testing, Dr. Gordon?
So one thing is, it tells me, how long I've been doing this job. I tested them back in the 90s. So I don't know what the mutation was that was found. I'm just not remembering the family. But so absolutely. So that brings up a lot of things. One is fear of employment discrimination, genetic testing, and that implication for unaffected young people. And so since we are talking about colon cancer and the risk to younger people, it's a really important time to bring this up. There are very comprehensive anti-discrimination laws, both for protection of health insurance and for employment for anybody who has a predisposition to a hereditary susceptibility. When you're talking about saying, committing somebody to very frequent colonoscopy who may not be at risk, this is the family where you can clearly know the power of the genetic testing is you are at risk or you are off the hook. And so to make somebody undergo an invasive procedure who may not be at any increased risk, to me, it does not serve them well. So we always talk about this individually with each person, kind of seeing where they are in their lives and anything that needs to be done ahead of time for genetic testing. But absolutely, genetic testing would be entirely indicated. The other thing is that in people who were tested years ago and tested negative, the update testing, we have such improvement in both our molecular technology as well as the number of genes that we now test for colon cancer, that anybody who had a prior negative test, prior probably to the last 3 or 4 years, should probably have a reevaluation and update genetic testing for these big panels, which we now do all at one time. The other element to that is that, and I have just lost my train of thought, so I will come back to it. But so basically, yes, they should have genetic testing. That should be talked about in terms of their fears and concerns for discrimination. That is not an issue. And the power of being able to know whether they're at risk not only for colon cancer, but potentially for other malignancies that they need to be screened for also.
All right, good. Dr. Bedford, question about diverticulosis. How does that relate to colon cancer?
It doesn't. So diverticulosis essentially is an outpouching of the colon wall, of the lining of the colon through the muscle layer in the wall of the colon itself. It more relates to the lack of fiber in your diet, thereby a chronic constipation over the years. I would say about 50% of people over the age of 50 will have diverticulosis, which does not translate to any risk of colon cancer. It's just truly a matter of keeping your bowel movement soft with more fruits, vegetables, and at least the proverbial 6 to 8 glasses of water a day.
Great. Does aspirin prevent diverticulosis? Any role there?
No. So aspirin is an anti-inflammatory, as we were relating to colon cancers. No, does not prevent diverticulosis, which is not an inflammatory disease. Diverticulitis is if the osis happens to, to break open and cause an inflammatory reaction. Typically, patients are treated with antibiotics. If it is severe enough, they may even require surgery, but aspirin truly plays no role.
Dr. Fischer, after a person has colon resection to treat cancer, are there any changes in their lifestyle, their diet, their likelihood of having gastrointestinal symptoms?
Yeah, most people know. Most people over a period of time sort of adjust. So as we all, just as a refresher, the colon's 2 main functions is to reabsorb water and to be a reservoir, allowing for you to stool sort of when you're ready. And so when you remove a significant amount of that, some people have more frequent stools. Some people have and they can modify that with their diet. So we ask patients a lot of times to journal what they eat and figure out sort of what foods sort of move through them faster, and sometimes even use medications to slow that transit down. When we're doing the connection very low to the anus, it's very low connections. Sometimes we get a little bit of discomfort with frequent stools. And sometimes, very, very rarely do we have to do anything surgically to try to fix that. But the vast majority of patients, after a period of 6 to 8 weeks after their surgery, they sort of learn to adjust to the changes and are able to modify any dietary changes or identify dietary changes that may make them feel bloated or then have more frequent stools.
Okay. Dr. Fischer, I know you're involved with numerous research studies in the Cancer Institute. Can you tell us some of the things that might be going on, research regarding colon cancer?
Absolutely. So, as the Institute's had a long history of sort of using the immune system and how we use that to treat some cancers, started off very early on with melanoma, and now we're trying to figure out, these medications that that have been developed that work very well in some cancer. We're trying to figure out what indications can we use those in other cancers. And so, so evaluating how the immune system, we have clinical trials that use these immune therapy drugs in patients who have failed standard chemotherapy or have, significant mutation burdens that may make them more susceptible to be able to avoid the chemotherapy. So those are some of the clinical trials that we have ongoing. And we have a very busy biorepository where we collect blood and urine samples to discuss changes in treatment, as well as be able to predict recurrences through non-invasive or liquid type biopsies. And then thirdly, we do a lot of sort of outcomes-based research. And I've been involved in a lot of that with the fellows as we've trained using sort of these large national databases to look at, thousands, if not hundreds of thousands of patients, and look at socioeconomic factors that cause, certain people to present at a later stage. And so how that sort of all ties into healthcare, access to healthcare, should we be screening earlier in these patients? Should we be looking for different things in these different populations, whether that's race, sex, ethnicity, all the above. And so that's something, in fact, I'm thinking of a fellow from a few years ago actually won an award at our national meeting based looking at disparities in presentation of colon cancer. So that's sort of the three fronts that we continue to do research on at the Institute.
Terrific. Well, the area of recruiting the immune system to fight cancers, immuno-oncology is a hot, rapidly moving area, and one that's being specially emphasized amongst the clinical and research translational laboratories at the Cancer Institute. So more exciting developments to come from those efforts in the next couple of years. Well, one more question. Susan asks, my husband was diagnosed with stage 4 colon cancer at age 54. The colon tumor was quite large and it spread throughout the liver. He previously had a screening colonoscopy at age 50, which did not detect any tumor. What are the chances of having a small tumor that may have been present previously missed at a colonoscopy, Dr. Bedford? What are the chances of a negative, falsely negative colonoscopy?
So the stats are that approximately 11% miss rate with a standard colonoscopy. Much of the colonoscopy depends upon the type of preparation that is there, whether it's a good prep, bad prep. If there was a polyp that was missed, again, as I said, there's about an 11% rate, as they may hide within a fold that just wasn't seen at that time. But there are, unfortunately, tumors that do arise, especially depending upon the genetic makeup of the patient themselves, that might arise within that period of time.
Yeah.
So in this particular case, sorry to interrupt, but I want to finish Susan's question here. 54-year-old man has a large cancer with metastases. At what age should the patient's sons be starting to get colonoscopy? At
least at the age of 44.
Okay.
So I think Dr. Gordon had something to say.
Sorry, Dr. Gordon.
Yeah, no, I mean, this history, certainly those children should all undergo genetic testing, because an advanced cancer at 54 very well could have been part of a hereditary syndrome that either, as Dr. Bedford said, grew up in the interval, was truly negative when he had his screening at 50. That's why we do the colonoscopies every year in our super high risk patients, not every 5 or 10 years.
Okay.
And also to help define that. But otherwise, I agree that 10 years prior at least.
Very good. Thank you. That's
Dr. Martin?
Yes.
It's 1 o'clock, so I think if you don't mind, I'm going to wrap this up real quickly and just say thank you to everybody, to all the panelists. This was wonderful, and it's so interesting how much more new information we hear every year. So I feel like I've heard you guys through the years, and every year I learn more. So this is just incredibly valuable to all of us, and thank you very much for your time for this. It's great. I wanted just to let everybody know that we do this monthly, these wonderful Be Inspired series. So next month, we're going to be talking about Understanding Cancer-Related Cognitive Impairment. We're going to have physicians from our brain health program, two psychiatrists that work in brain health and cognitive impairment, one who is a psycho-oncologist and focuses her work on cancer patients. And then we'll have medical oncologist Trevan Fischer, who's going to be joining that talk as well. That'll be on April 27th from 12 to 1. In May, we're going to be talking about game-changing technologies for brain cancer. So Dr. Santosh Kesari, Dr. Martin, who's a neurosurgeon, will be on that, Dr. Garni Barkadarian, and a number of researchers. We've got a wonderful program that's going to be coming up on brain cancer. So that we're looking forward to in May. And in June, we're going to do the survivorship umbrella. We're going to be talking about cancer supportive care services and palliative care at St. John's, and talk a little bit about how it all intertwines with all different types of cancers. So that we're looking forward to on June 22nd. And I just wanted to thank you for all of your interest in our work in colon cancer. Your support really makes a difference in the work that we're able to do, in the clinical trials that we're able to run, and at the St. John's Cancer Institute, and that furthers our knowledge and treatment towards cure. So thank you very much for being here today. Dr. Martin, did you have anything else to say?
No, I'd just like to thank the panelists, Dr. Bedford, Dr. Fischer, and Dr. Gordon, for some great information. I learned a lot, and I'm sure our audience did as well. Thanks.
Thanks, everybody. We'll see you next month.